All right. Hi, everybody. Wow, 7 of you already there. Look at you guys. Hi, Carmen, up there in Naples. We'll be coming up there shortly. And hi, Donna Lynn in South Jersey. And Tammy Lewis. You guys are so prompt. And Beth, hey, Beth, how you doing? What is it? It's Thursday, right? May 14th. All right, so you guys know what I always look up because these are so much fun. I mean, the list, if you guys actually saw the list of how many national holidays there are on any one given day, it's crazy. I just pick out a couple. Wouldn't you know that I picked out National Buttermilk Biscuit Day? Wouldn't that be a nice thing to just like bake some of those? Are you guys into baking? How about you, Vincent? Hey, you into baking? And hi, Christy Getch from Battleground, Washington, and Jeanette. Hey, Jeanette from Lisbon in North Dakota, and Rebecca. Hey, Rebecca Malik, how you doing? And I also have Rebecca Franick and Candy Fox Merkin. So you guys, it's also, as you know, it's also Better Sleep Month. Have you guys been having trouble sleeping? The experts that I've watched on TV say that because of all the anxiety that people have had trouble sleeping. What about you guys? I always have trouble going to sleep. I take some melatonin and that does help, I think. But I think I'm going to find an expert to talk to us about sleep issues because I talk about it in the book that Sleeping Beauty is onto something. Hey, Louise, otherwise known as Lulu. My daughter Lindsay's married to Evan Weinberg, and Louise Weinberg called me up before their first baby was born and said, I think I'm going to go by Lulu. Why don't you go by JoJo? So that's how I came to be called JoJo, as some of you who follow me know that. All right, so Donna Lynn, you're having trouble sleeping. Someone's saying from overseas, I want to marry you, and tells me how to get in touch with them on WhatsApp. Why don't you just join me every day at 1:00, okay? Penny, I look great, thank you. That's so nice. Hey, Anne-Marie Picciano, and you are one of Dr. LoRusso's patients, and she's going to be here with us in just a few minutes because we are going to be talking mammograms today. So right now you have a chance. If you want to call, but don't lose me on your phone if you're watching me on your phone. If you're watching me on your laptop or your iPad, if you know any women that should be listening today, because we're going to talk mammograms, we're going to talk about how to, keep ourselves healthy, then this is the time to do it. And here's Wendy Force from Coscob, and she also goes to Rye Radiology. So we have a lot of people. I'm going to come back and try to get some of you in. Hey, Amir Pehel. He's my hair and makeup artist. And I really, really missed him. So anyways, Better Sleep Month, the month of May, that's when better sleep is observed. It's also Health Vision Month. And I mention these things because maybe it's time, and you'll hear today, some medical offices are opening back up. And I've noticed that my glasses might not be doing the trick. So I think I might need to go and, get retested. It's also Melanoma Skin Cancer Detection Month. I mentioned that, and I'm going to get us an expert. Have any of you never, ever had a head-to-toe skin check? Because they say that a lot of people, oh, hi, Amir, you're saying I miss you too. Have any of you, and I'd love for you to answer me, if you've never had a head-to-toe skin check, it's just not been kind of in your wheelhouse, your consciousness. It is the most preventable cancer, skin cancer. And so I kind of want to get a reading on you guys. And women are sometimes just, I don't know, a little embarrassed. I'll admit it. And if that's the case, then find a doctor that you're comfortable with to go and get. If you work with a dermatologist, but maybe it's a guy, then find a woman. You don't have to leave that derm, but find somebody that you're willing to have a head to toe skin check with. All right. National Women's Health Week. You're going to see a lot of postings from me about that this week. By the way, it's also National Moving Month, and I'm actually moving my office. It's some of it's happening right now as I'm here, all dressed nice and white, and there's some people over there starting to move. We've been packing for the last 2-3 days, and tomorrow's the big move into a smaller office. I just realized, quite honestly, with this pandemic, I've come to find that I don't necessarily need a great big office with a lot of people. Look how I can do a lot of things from home. There's going to be a lot. Our new normal is going to be, I think, really new. All right. So today though, we are going to talk mammograms. And I just think this is so important. So listen up. And if you want, go get a pen and take some notes too. Because I've actually been receiving some messages from some of you a little bit, concerned or actually freaked out because your mammograms got canceled. All right, so we're going to talk about what you should do about that. Because pandemic or not, women are still going to get breast cancer. And we know that the earlier you catch breast cancer, the better your prognosis is going to be and the better chance of you surviving it. My triple negative breast cancer was found at Rye Radiology, not too far from me, on June 5th, 2014. Those are days that you remember. And I had gotten a 3D mammogram that day, and it was clean. And then I walked across the hall and for an ultrasound, and I heard those words you never want to hear: you have cancer. So, Rye Radiology, like businesses everywhere, has had to close their doors in March. They just started reopening now for urgent cases, but they're making plans right now to reopen for regular checkups, and we'll find out what that's going to look like. We're going to be speaking today with Dr. Diane LoRusso, and she founded Rye Radiology in Rye, New York, and Rye, New York is right next to Greenwich, where I am, Greenwich, Connecticut. She is a diagnostic radiologist specializing in breast imaging. She's been named with, best doctors and New York Magazine and Castle Connolly, that doctor's office magazine. For I don't even know how many consecutive years she's been named one of the best doctors. She's been doing mammography for 46 years, and she's been doing screening breast ultrasound for 32 years. She was really early on the scene with that. And a lot of us actually need that ancillary test. And she'll talk about why, and you'll be able to understand if you're one of those. All right, so let's bring Dr. Diane LoRusso in, and I'm so happy. Hi, how are you?
How are you? Good to see you.
I got to tell you, there's been so many people. Betty Walensky. I've been going to Rye Radiology for 28 years. Here, let me see if I can pull her back down. Tanya Wilk. We know Diane LoRusso because she and her partner, Gail, are involved with my agency cancer support team. Mm-hmm. And they help. And by the way, cancer support team helps women get mammograms at no cost. You have so many people here saying hello to you. It would take the whole time.
Thank you. Hi, everybody.
Linda Rosenfeld. It just goes on. Betty Walensky. Just so many people. And hi, Karen Podrosky from Louisville, New York. Is that right? Louisville, Kentucky. I'm sorry. I should have come right off the end of my tongue. Here's Gail Weezy's. Okay, so she has questions. So we'll get into questions in a minute. But I want to talk today, first of all, we've had a number of women who got their mammograms canceled, of course, during the last 7-8 weeks. I don't know where we are. I think most women know that this is our best screening tool and that you want to find it as early as possible. So what do you say to those women who got their mammogram canceled?
Well, the COVID crisis is new territory, and we closed for 6 weeks for the safety of our patients and the safety of our staff. Yeah. And so mammography has been put off. It can be put off 4 weeks, maybe 8 weeks now, 12 weeks, but never skip. Just because it could be put off a little bit, don't skip this year's exam. It's a must. And what we're doing in the office is we're starting screening, and In June, we'll screen women over 70. Right now, we're starting to do women under 70. And there are two reasons for that. One is that breast cancers are slow growing in women over 70. And also they have more risk for complications from COVID. So it's important to know that not all breast cancer is the same. There are breast cancers that are slow growing, and they take most of them are slow growing and they take years, but there are some that come up very rapidly and they could double in size in several months. So therefore, I stress that women should make an appointment for the mammogram whenever their radiologist's office feels comfortable doing mammography.
And we know, I mean, obviously, Dr. LoRusso, you know that I was diagnosed with triple negative. Now, when I first heard those words from my breast cancer surgeon, Dr. Barbara Ward, I thought, oh, good, at least I'm negative to 3 things. And then she explained it to me.
Right.
That there are 3 kind of buckets of breast cancer. There's estrogen positive, there's progesterone positive, and there's HER2 positive. Triple negative means that you don't have any of those receptors on those cancer cells. So all those great treatments that they've found for those kinds of breast cancers
don't apply to you.
There really weren't any treatments other than just really, really aggressive chemotherapy and radiology and of course surgery. So mine, if I had not been there at Rye Radiology that day and gotten, of course, I got an ultrasound, which is where you found it, but if I had waited 18 to 22 months later, I might not be here talking to you today.
I don't think it would.
I wouldn't then.
Correct. I think that's correct.
So that just goes to show you, everyone listening, and remember, men can get breast cancer too. So Vincent and any of you guys who are also on here, they might have left when they heard we were talking about breast cancer, but you can't know. You can't even know what your breast density is, which we're going to talk about in a minute, from just how your boobs look. You have that. You can only find that out in a mammogram, and it is our gold standard as of right now. When you're going to start opening up again, and what should women expect now? I'll just say, what are your protocols that you're putting into place?
We have very stringent protocols, and our office doesn't look the same as when you last saw it.
Wow.
We screen patients on the phone with the COVID questions. They are given a cell phone number to call from their car, and they wait in the car. We have no common waiting rooms. We have spread out the appointments further apart during the day, extended the hours earlier in the morning so that less women are in the office. We're not using the waiting room. Dr. Calamari's husband built plexiglass windows at our front office, and we are greeting the patients individually at the door. One of our personnel comes to the door with a mask and gloves, and the patient has a mask. They come in, their temperature is taken, they have to Purell their hands, and then they're only taken in when the room is ready for their exam. So if they're coming for a CT or an MR or a mammography, they're not going to be taken in and wait. They're going to be asked to go back to their car and then come in when the room is ready. And then we're cleaning all day long. We're sterilizing surfaces, machines, shelves, doorknobs. It's a constant cleaning process. So there are other things, but the personnel, our personnel, are all masked and patients are masked, but there's a lot of cleaning and certainly a lot of space between patients.
We have Leslie Wensley, I think, and she says that she's in Michigan. They're still sheltering in place. She called her oncologist, but they refused to take any spots for mammograms until the end of July. And what if you have the BRCA gene and you really need to be doing those? I think probably the most important thing that we should emphasize is don't let it just come off or go by. You know, if you keep all your appointments on your calendar like I do,
right?
Move it, move, take it off the day and move it to like June 1st. and then call back again, right? The whole
Yeah.
thing is
That's
don't let it pass.
absolutely don't. Just keep calling, right, until you can get an appointment. Right.
And are there have they had certain places in cities where they saw, like, if somebody felt a big lump, where they could get them in?
Yes, I mean, there are some places that stayed open. We closed for 6 weeks. So we had women patiently waiting who had lumps in their breast during that time. And last week and the week before, we were doing biopsies in the office.
Oh, okay.
We started doing that.
So let's talk mammograms and breast cancer. Mammography, as I understand it, has gotten significantly better in the last number of years. And now we also have 3D. What's it called? Tomosynthesis?
Tomosynthesis.
Tomosynthesis.
Yes.
And those are, I think, exponentially better. Do you want to tell us the difference between the two?
Sure. 3D tomosynthesis is the biggest improvement I've seen in mammography since I started 46 years ago. There have been technological improvements, but the way 3D works, it looks like a mammogram machine, and your breast, unfortunately, still has to be compressed. And with a regular mammography machine, you have a tube overhead, that's the X-ray, and it takes a picture. Well, with tomosynthesis, the tube moves through a very slow arc, and it's taking pictures from different angles at very low dose. So the dose of the exam is the same as a regular 2D. And as a result of this, you get a regular 2D mammogram, but you get millimeter thin sections through the breast with very high detail. It's like getting a CAT scan at low dose. And
so instead of a flat picture, it's almost like you can almost like get right inside that breast and look all around.
What you see is slice after slice, like pages of a book. A slice, 1 millimeter slice, then the next, then the next. So there may be 50 or 60 for each projection. So if you have 4 projections, that's another 200 images. And so it takes a little longer to read, but it's so much more accurate. And we were one of the first in the country to get it. And it was FDA approved in 2011, and we got it in 2012. At that time, there were almost 1 million cases done in Europe, and the results were astounding. And the largest study came out of Norway, and they found 40% more invasive cancers. 40%. And so it's
unbelievable.
It was huge. And it works in all breast densities. It works if you're dense, but it's not perfect. Nothing is perfect. And I want to just stress that there's no way to detect breast cancer that's 100% accurate. Not mammography, not breast ultrasound, not MRI. And even women who have the BRCA gene and remove their breasts still can get breast cancer from a few cells remaining. So there's nothing 100% in this.
Wow.
So now the other thing that if people don't know what invasive cancer means, there are in situ cancers and invasive cancers. 90% of breast cancer starts in the milk duct, and 10% start in the lobules. And let's just take ductal cancer, the more common. If it stays within the duct, it's called in situ, in place. Mm-hmm. If it destroys the basement membrane and it goes into the tissue of the breast, where there are blood vessels, arteries, veins, lymphatics, it becomes mass-like. It's invading the tissue. It's more likely to have deleterious effects because it has now spread to areas.
A way to spread.
Right. So, so the other advantage, so we're finding in some reports found 65% more invasive cancers, which is amazing. The other thing is that right radiology is different than most other practices in the US, in that we read while the patient is there. We read the mammogram, their screening mammogram. If they need a diagnostic workup of anything that's questionable, we do it right there. We don't send them home, and they
might not come back.
Get that letter. Women don't have the anxiety of getting a letter in the mail.
Yeah.
You have to come back. Okay. So, but since sending women home is the more common practice, The advantage of 3D also is there are less false positives and there are less callbacks. So, and depends what you read. It could be anywhere from 17% to 35% less callbacks. So that is a huge number of women who don't have to worry unnecessarily.
I remember when you guys, said you've got breast cancer, that I remember your partner, Gail, she said, I've got time. I'm going to do the MRI right now, the biopsy. And I had something really important to go to for one of my daughters. Mm-hmm. And she had also had her daughter in the same gymnastics program. She said, I know that day it's important, but I trust you that you'll come back tomorrow morning. Right. Right. To get them. It's interesting. We have somebody right here. You want to put Christine Kraling back up? She says, what advice do you have for women who were already apprehensive or anxious about getting a mammogram prior to COVID-19, who may be used to going with a family member or friend? Do they now need to adjust to the new protocol? You won't be able to have
something. If somebody tells us that they can't have a mammogram without emotional support,
okay,
that's a different story. But we have patients who've come year after year with the same friend.
Oh, okay. All right. So whatever gets them in there.
Yes.
The important thing is just to get
have it done. I
have Betty Walensky says, I'm due for a breast MRI. I have the BRCA gene. Are you doing them anytime soon?
Oh, we are doing. We have been doing them.
Okay. So Betty, call and make your appointment. Since we know that 3D mammograms are so much better than the old type, are most referring physicians now writing the script for the 3D?
Yes. And the good news is also that Medicare covers it, and so do most insurance companies now, almost all.
Okay. You know that I've been out all over the country talking about the need to tell women when we go to get that mammogram. For decades, our referring physician has gotten a letter saying down at the bottom, this woman has dense breast tissue and may need an ancillary test. But we weren't being given that information.
Not if you went to Rye Radiology, Joe.
Okay.
That information since the 80s.
So I had a clean 3D mammogram that day.
Correct. Yes.
And I, of course, went across the hall and I had an ultrasound and I heard those words that none of us want to hear. You have cancer. And that was because I have very dense breast tissue. Now, not every woman I have found from all my travels around the country, it's not just not every woman. I have found that most women didn't really even know what dense breast tissue was. And I'm going to tell you, I didn't know. Like I would always say, when someone would come out and say, we need more pictures, like you get so anxious, they freak out. And I would always say, oh my God, did you see something bad? Right. And they always say the same thing. No. It's just that it's hard to see anything because you have such dense breast tissue. But I didn't know that was a thing. I didn't know that was something I should understand. So explain to women dense breast tissue and any men who are on this, because remember, men can have breast tissue.
Dense breast is a radiologic term. You can't tell if somebody's dense by palpating their breast. Breast is made up of fat and other elements. The fat is the background of the breast that's gray on a mammogram. And things that are white are the breast glandular tissue, the fibrous tissue that some women have a lot of. It's like scar tissue, the same kind of cells. And cancers are also white. So the fibrous tissue is white, the glandular tissue is white, and cancers are white. So it's harder to see when your breast is dense.
I've heard it's like looking for a snowball in a snowstorm.
Yeah, kind of. Yeah. And some women's breasts. Yes, absolutely. So
would you just explain that when we're younger, we tend to have dense breasts?
About 60% of women have dense breasts before the menopause. After the menopause, the tissue, the glandular part of that tissue involutes. So you have about 30% of women have dense breasts. And they will have dense breasts their whole life. because the fibrous component never goes away. So they're 90-year-old women with extremely dense breasts. And so ultrasound is a must in those women. And so when women came to radiology since the 1980s, I've been recommending doing screening ultrasound. Now, during the 1980s, breast ultrasound was done usually for a lump. And whether it was a lump found on a mammogram or a lump found on physical exam, it was a lumpogram. But I always looked at the entire breast tissue in both breasts. And in doing so, I started finding benign tumors, but then started finding cancers that were not on the mammogram and not on ultrasound. So I found hundreds and hundreds over the years. My first patient I mentioned to you the other day, my first patient in the 1980s was in her 40s when she had cancer on ultrasound. She had a normal mammogram, normal physical exam. She still comes every year to radiology. And last year, she had another ultrasound detected cancer, normal mammogram, normal physical exam. So it's a very good tool. And I can't stress enough how important it is. And thankfully, you've been an advocate for getting legislation, and your friend Nancy Capello, passed, has done
breast cancer
service. I mean, her family should know what great service she did and saved so many women's lives, I'm sure.
Dr. Nancy Capello she did a grassroots effort, and she started in her home state, which is my home state now, Connecticut. We were the first ones to get legislation passed for mandatory mammogram reporting, which means that the woman, the patient that goes in, should get that information. And let's talk about why it's so important to get the information. And if any of you are of the age that you're having mammograms, which we're going to talk about in a minute as well, and you don't know your breast density, call your radiology lab or look at that last letter that you got, because you need to know. It's broken up into 4 different parts, very fatty, mostly fatty, kind of that iffy area, and then the final area, which is very dense. And if you're in the very dense, you should absolutely be getting an ultrasound. And you're
also heterogeneous. Also, if you're heterogeneously dense,
yes,
there's some that are not dense, but a very small part of their breast is dense, and only the radiologist can say whether you need the ultrasound in those instances. Because there are people where 75% of the breast is fatty and a small part of it is extremely dense. And we know we can miss things in there.
Well, here's Mara Savard. Mine was found by a good radiologist listening. I had enlargement in the breast. Only the MRI found my cancer, not any other test. So always take advantage of all the tests if you think there is a problem. Most women that I've talked to said they had this, like if they found, most women I talked to found their own cancer. Like I would never have found mine because mine was back against the chest wall. But a lot of women find theirs. The woman who wrote my book, Had I Known, with me, she had a clean 3D mammogram, and 2 months later, she felt something and went right back in, and she ended up being BRCA. She ended up with a double mastectomy. Mm-hmm. So, if you think something's wrong, like women tend to say, you'd like to think that maybe it isn't anything, so you don't go. You've got to go in and get it.
Also, even if you don't think anything's wrong, we didn't finish the dense breast, because if you have a dense breast and you have risk factors, there are risk factors that require you to have an MRI. I mean, if you have a gene, you have to have regular screening with MRIs. If you had a father with breast cancer, you need regular MRIs. If you had a previous radiation for lymphoma, the chest wall that increases your risk, you should have an MRI. I mean, a whole bunch of risk factors, major risk factors, where you should get regular screening. So, in addition to mammography.
A lot of women, Diane, say, how could I have breast cancer? I'm fit. I don't know of any family history of it. I eat well. I exercise. And that was kind of me. I just didn't think I would be one. So
Right.
what is, and it's, I know your answer. So, you know,
Okay.
the biggest risk factor.
What's the risk factors? And I have a long list, but there's one risk factor: being female. That's it. And most people don't realize that more than 75% of women who get breast cancer in this country have no other risk factor than being female. So it's really important to know.
Had I known that, which is why the book got named Had I Known, if I had realized that less than 15% really had any family history to speak of, I wouldn't have been so nonchalant, because I'm going to admit to everyone, okay? I went back and I requested from you guys all of my, every letter from, I think it was almost 20 years, maybe 18 years. And I found by looking at those that I had skipped a year here or there, where it had fallen off my cancer. And it's like, oh my God, I was like, no, so nonchalant, because I just didn't think it was going to happen to me.
Right.
Thankfully, the year I had it, I was not nonchalant.
Right. Right. I want to go over the risk factors of the risk factors that makes it higher. We're all at least a 1 out of 8 chance of having breast cancer. Okay. And so, but there's some women where the risk is much higher. And people have heard of the BRCA1 and BRCA2 gene, but now there are like 15 other genes that we know increases the risk of breast cancer that are being tested for now. If your mother or sister had premenopausal cancer, if your father had breast cancer, if you had breast cancer, you're greater risk of developing a new cancer. So I want to go over the rest of the list. If you've had atypia on a previous biopsy, whether it's atypical ductal hyperplasia, atypical lobular hyperplasia, or something called lobular carcinoma in situ, those are all major risk factors. And I had mentioned before, if you ever had radiation when you were young, high dose radiation for lymphoma to your chest, you need MRIs yearly. And if you've had previous ovarian or endometrial cancer, increases your risk. If you've gained 44 pounds after the menopause, and if you have dense breasts, it does increase the risk about twice. So that's the double-edged sword with dense breasts. It makes it harder to find, but you're slightly more at risk. But you're more likely not to have breast cancer than you are if you have dense breasts.
Let me ask you, because I've heard that if you are heavy, overweight, that estrogen gets stored in fat cells.
Yes.
And that in and of itself puts you at greater risk.
Yes.
Being overweight?
Yes.
All right. So those women should be extra cautious.
Yes. And then the other interesting thing, and we don't know for sure what causes it, women with very high bone density, I mean, above average compared to a 20-year-old, have a higher incidence of breast cancer. And maybe one theory is that they store estrogen differently in their body than others. I mean, it could be a genetic link or whatever. We don't know. But if I have a patient come to the office and they have a bone density and I say, oh my goodness, look how high their bone density is, I will talk to them, make sure they have screening, and make them aware that they have a risk factor.
And of course, I've always had all of my bone density screening at the same place with you guys as my mammogram. So you know that, you know what my bone density is.
Yeah.
On getting genetic testing, I've been hearing from a lot of women that as soon as they find out that they have breast cancer, that they do the screening. Has that become more common?
Yes, definitely.
I hope the answer is yes.
Yes, yes, it is. That women who are diagnosed with breast cancer, particularly younger women, will have genetic testing now routinely.
You know, what's the best thing now? Things to prevent breast cancer. I mean, we don't really know why more women are having it and why so many younger women are having it. You can point to a lot of toxins and in whatever we eat and hormones and all that. But you and I've talked about this, and you say that one of the best things you can do to really, help prevent, quite honestly, any kind of cancer is exercise, cardio.
Yes, yes.
So how important is this?
Before we get to the exercise, I do want to point out that the first time the incidence of new cases of breast cancer went down was after the Nurses' Health Study came out that showed that hormone replacement increased the risk of breast cancer. And then women stopped taking hormones, and it was the first time over a 3-year period that the number of cases started coming down. So I don't want to forget about that.
Yeah, and we shouldn't forget about that, Diane, because you know that I was on estrogen replacement. And my gynecologist and myself, we had discussed it, and we felt that since I did have a history of heart disease in my family, that there'd be maybe some protection. And, you know, I went back afterwards and said, we shouldn't have, you let me get away with convincing you that.
But your estrogen, but your tumor wasn't estrogen.
I know.
So that,
mine wasn't estrogen. Yeah. So probably what I took had nothing to do with my breast cancer. But still, we have to be smart, because I think just like, you know, we might look at a room and say it's not really dirty. It's because we didn't look behind the sofa and see all the dust. We like to say, I don't have a history of this, so therefore I can take the estrogen because I hate my hot flashes. So I think that we talk to ourselves, and we talk ourselves into, you know, not having to be more careful. Like we go into that nonchalant mode.
Well, let's get back to exercise, because that's what you really asked me. So exercise is like an elixir of youthful youth.
It is.
And because it, you know, reduces the risk of heart disease and stroke, diabetes, dementia, and many, many cancers, breast cancer being one of them. There was one study that showed that people who did like 150 minutes of walking, some kind of good exercise every week, they followed them for 11 years, the ones who exercised, the ones who didn't, and the ones who exercised had a 10% less incidence of breast cancer. And this was done for all cancers. So 13 out of the 26 cancers showed marked improvement and a reduction in incidence of cancer. One of the cancers, however, that increased was melanoma, because those people might be outside a lot. So nothing's perfect.
So wear sunscreen when you go outside.
Right. And you should know your family history too, genetics.
We have a few questions here. Is it true that we shouldn't wear underwire bras? This is Sue Jeffries is asking it.
Well, you know something, I recommend that patients don't, because they get a ridge under their breast, and it gets kind of indurated, and then it's harder to do a physical exam. I mean, it doesn't cause cancer, but sometimes it causes symptoms like the inside part of the wire can constantly irritate one portion of the breast, and the patient comes in and feels a lump, but it's just hardened fat. So that just happens, but there's no danger in it. But I just tell patients if they could avoid it, not.
And here's Laura Morton saying, my lump was not there one day, and then one day there it was. Yes. And that kind of points out why it's so important not to ever skip a mammogram.
And also there's so much misinformation in the media, like that self-examination is not important. But self-examination is extremely important. You said you know so many women that found their own cancer. Yeah. They're called interval cancers. Interval cancers occur between the yearly screenings. And they're not that common, but they happen. So women should examine themselves once a month, whether they're premenopausal, postmenopausal. They should do it when their hands are soapy in the shower. They should do it when they're lying down. And women still find their own cancers.
Here's Rizelle Abrams, who I know personally. I found my lump in the shower doing my self-breast exam. And I've seen articles in women's magazines that say it's really not that important to do self-breast exams. I mean, to not know you're normal, how are you ever going to realize if something's...
It's a must. That's one of the things that is so important, and it's not stressed.
So here's Pat Little. I have dense breasts, found a lump myself after a negative mammogram. I had to insist on an ultrasound. Here it is. I was treated with chemo and radiation for stage 2 triple negative breast cancer, followed by a lumpectomy. But now I'm going on 6 years. Sounds like she has exactly the same as me.
Like your sister, twin sister, right?
Separated at birth, huh? Here's another one. I mean, a lot of these women are saying, there's another one about the not wearing the underwire bras. So no underwire bras?
You can wear underwire bras.
I have underwires.
I mean, it's very hard to go into a store and find one that's non-underwire, but they do exist.
Yeah.
There's no literature that says it causes any increased risk. It just causes a problem if it irritates the breast tissue, and then the patient gets nervous. They feel a thickening, and it's really just fat that's hardened where something's been pounding at it for a long time.
I also saw a question that somebody has lumpy breasts.
Yes.
And does that mean that they are like cancerous or that they are dense?
Well, usually most women with lumpy breasts are dense, but not always. And it doesn't increase your risk just to be lumpy. It just makes it harder for a physician to do a physical exam or you to do self-exam. But there are some women where the examination is difficult. So when I examine a patient that has lumpy areas, I draw where these areas are year after year. And once, many years ago, there was, a patient who had very lumpy breasts, and she had one little area that felt was new. And, I remember her doctor saying, oh, Dr. LoRusso is so cautious, and it's nothing there. And there was nothing there. On mammogram or ultrasound, they said, please go see a surgeon. She had cancer.
Here we have Maureen McCabe. I found my own in between mammograms. It was also triple negative breast cancer stage 2. I guess that's also because triple negative, as you say, is an interval cancer. It can pop up and grow exponentially, right?
Correct.
Very quickly.
Yes.
Unlike those other estrogen positive kind of things that take years and years, right, even decades.
Yeah. I mean, the doubling rate for breast cancer is anyway from 1.5 months for the fast growing ones to over 2 years. And women in their 40s tend to have a higher incidence of faster growing cancers. So that's important.
Wait, did you just say in their 40s?
Their 40s have compared to women like in their 70s. So we were going to talk about screening women in their 40s, I think.
So first of all, we've got somebody who's 70, Marion Lowry. I recently turned 70. Yep, 1950 birth for her. Should we stop getting mammos?
No.
Later age?
Not. Every year, as long as you're healthy. Absolutely.
See, that's so important. And it's not even just the mammograms, ladies. If you've read my book, time for a shameless book club of the day. Why did I come into this room? I go through all of the tests that we should have on an annual basis. Or some of them, you might not have to have a colonoscopy, for instance, on an annual basis, but all the tests are in here. And one of the things that I talk about, even with your gynecologist, you need to keep having your gynecological exams when you're into your 70s and I guess into your 80s. I didn't ask, but because there are all kinds of things that can happen. And there's also, we'll talk about it one day, issues that present later in age having to do with your vagina and the thinning of the layer around the vagina, which can cause all kinds of issues, discomfort with sex, etc. So do not stop having appointments when you're in your 70s. I forget her name, but you and I will both do this, okay? Because believe it or not, I was also born in 1950. So I'm going to turn 70 in September, which I can't really wrap my brain around, but I know what do we do with these recommendations that like the preventative task force that says,
please.
Don't start having mammograms until you're 50 and have them every other year. And there's not one doctor.
I really want to talk to your audience about that because it is so important. Women have to have yearly mammograms in the 40s. When you take the population of the United States, the women in the United States, 1 out of 6 women who get breast cancer in this country get it while they're in their 40s. That's a lot of women. It results in 25% of the mortality for breast cancer. So women who get breast cancer in their 40s account for 1/4 of the deaths of breast cancer in the United States. And then if you think about how long these women would have lived, it's almost a half of the years of life lost to breast cancer in the United States is from those who got it in their 70s, in their 40s. So it's so important to have screening. The task force did a very terrible thing. There was nobody, and that was about 10 years ago, there was nobody on that task force that was a breast specialist. They were primary care, ex health insurance company executives, epidemiologists, right? But no breast radiologist, no breast surgeon, no breast oncologist. There was none. So what it did was it reduced, the media just went crazy, and then it reduced women having mammograms. The first time was after that task force, which was totally false information that was given. It was sloppy. The math was wrong. I mean, everything was wrong with what they did. And it was very condescending to women because they said, oh, you know, women, there are too many false positives in women who are in their 40s, and they're going to come back and they'll be.
And it raised our anxiety.
Yeah. And like their life is not important. So, so it's interesting. Harvard had a study 3 years ago that showed that women who had metastatic disease, where the breast cancer had already spread and they presented in their 40s, 71% of them never had a mammogram in their 40s. 71% did not.
That tells you something, right?
Yeah, yeah. So women should have a mammogram every year from 40 on. Now, I personally, and this is my recommendation, recommend 35.
A baseline, right? A baseline.
Right, because in Westchester, where I practice, in Fairfield County, there is upper social class, and it's associated with a higher risk. And I did some work with statistics in the 1980s in Westchester, and we do have a higher incidence in the rest of the country. So there are people, so I recommend my patients to start at 35, but lots of times I don't see them because the doctor doesn't send them sooner. But, you know, relatives and friends of people I know, patients of mine, their daughters will know. But there are also people who need mammography before 35, and that's very important.
Is that because of family history or?
The several things. If they have the genes, the BRCA1 or BRCA2 genes, or any of the genes, they have to start. Some say 25, some say 30, and that means mammography and MRI. Okay, and then women who have a mother or sister, first-degree relative, with breast cancer before the menopause. So now, let's say your mother had breast cancer at 38. You should have mammography starting at 28.
10 years earlier.
Right, exactly. And there are people that get breast cancer at 25, so they need mammography, but you know, regularly every year when they're 35. People are going to have a breast reduction. They need a mammogram to make sure they don't have cancer and need a different type of surgery, you know, before then.
Interesting,
Right. And the people, the women I told, when they've had radiation, we talked about it, for lymphoma, high dose radiation to the chest while their breasts are developing, they're high risk, and they should be screened 8 years after they finish their treatment, or age 25, whichever is later. So they've got to be screened really young.
And by the way, it's the same for colonoscopy. If you have a relative who had colon cancer, you find out the age when they saw those polyps, and you start 10 years before that. I want to show, I think it was, okay, I lost her now, but it was a person who just said, oh, here we go, Joyce Huntington, have dense breasts. How difficult is it to get an ultrasound instead of a mammogram, and does Medicare cover? But explain why.
It would be very difficult to get an ultrasound without a mammogram in my office.
It's not
it's not the primary screening exam. And so I will not do an ultrasound unless a breast ultrasound, unless the patient has a mammogram. And it's not as sensitive, especially for an older woman, that they only 30% are dense, and the mammography will be much better in so many of them. So that's a very important point. I'm glad she brought it up. Ultrasound alone is not a good enough screening.
So you still do your mammograms, and then ask, and if you don't know what your density is, your breast density, find out where in those 4 groupings you are.
Right.
Because if you have very dense breasts, I mean, I guess it's that women just have to speak up with their referring physician or with their radiology lab.
Physicians do for us. They will say, put for screening mammography and ultrasound if necessary, and leave it up to us who see the patient. And then that's for a first visit. Once they know, then they'll say mammogram and ultrasound once the referring physician knows they're dense, because they can't tell.
So can you put up the one, Nicole, that was just there? Because that was kind of an important question. Linda Del Bene Rosenfeld, at what age should daughters be screened of women who had breast cancer post-menopause?
They can start with a baseline at 35, and they definitely should have yearly mammography for, every year thereafter. If there's postmenopausal, if they're 40 and every year thereafter, most women will have menopause at 50 or late 50, up to the late 50s. So they don't have to start any earlier than 35. They should have an ultrasound, and then maybe every year and a half until they're 40, and then every year thereafter.
And, we've talked about this, that I have 3 older girls. Everybody that followed me on GMA, a lot of them had babies at the same time that I did. And they are 33, 36, 37, and just turning 40. And they are all, by the way, they've all put themselves under the care of my breast cancer surgeon, so that they go in and the women in that office, they do the doctor it's not a self-exam, but the physician exam,
right,
on a regular basis. And they made sure they put themselves kind of under special care because of my breast cancer.
Yeah.
So is that kind of advisable if your sister and your mom had breast cancer?
That's fine. That's fine to see a breast specialist, but there should be imaging also. Yeah. So if I would examine the 37 and 40-year-old with mammography and with breast ultrasound, because they're likely dense, I would make sure they're all doing self-examination. And the ones that are younger, if they want to come in for just a baseline ultrasound, and then when they're 35, they should have mammography and ultrasound.
All right. I've got a bunch of calls to make to my 3 daughters, but I know that I have a virtual book club that I'm going to be doing an hour with in 7 minutes, and I know you have a So, Dr. LoRusso, thank you so much. Everybody is
My
just
pleasure.
I suggest that afterwards you go onto my Facebook page and look at this live, and you might even you might be able to answer some of the questions for these people. But we really appreciate your time today.
My pleasure. It's a very important topic, and I'm happy to do it. Yeah.
All right. Bye-bye.
Bye-bye now.
So everybody else, you know that tomorrow I'm going to be speaking with Dr. Judy Garber from Dana-Farber Institute. We're going to talk about what's on the horizon. What have been the big breakthroughs? I think most of us have heard about immunotherapy, but we might not exactly know what that is. And then they're the ones that give most of the money to the scientists around the world. So it'll be interesting to find out. I mean, it's such hope when you find out what's on the horizon, and especially for those who have metastatic breast cancer, because that's where a great deal of the research is now going on. All right. So I will see you tomorrow. Bye, everybody.